will be interested in doing a fellowship, a postdoctoral fellowship in a specialty, be it cardiology, GI, kidney, there are a dozen of those. So we've had quite a few do fellowships in different areas. Very proud of them, but also very proud of the ones who go into more general internal medicine. So that's kind of what we're up to doing this. And so right now we have two residents. These two are presenting this morning who work in the clinic, and they've changed it over the years from being a 4-week block at any one time to being 2 weeks at a time. And that sounds like diminishing your contact to them. Actually, the whole reason it was done was so that you'll actually more likely to see the same physician, because even though it's only 2 weeks at a time, they come back every 6 weeks, so the same ones. So that's kind of the way it's set up. And then in the last year, we've set up a position for a single resident to spend time for 2 weeks at a time in HCC, in healthcare center, special care center, and assisted living, to get exposure to that kind of long-term care experience. So Dr. Madine down here she's very relaxed because she's not presenting today, but she's spending time over in HCC this week. So with that as an introduction, I hope you agree this is an appropriate topic, and I'll make the case that it is, because hypertension is the #1 diagnosis among people who live at Butterfield Trail. I can say that without checking any records or doing any research. There's a rare person who doesn't have hypertension after a certain age, and it becomes more likely with age. And I won't divulge identity, but there's one person on this campus that I'm aware of. I haven't seen everybody, but one person who's in his 90s and doesn't have and never has had hypertension. That's pretty rare, pretty rare. But the good thing about hypertension, unlike a lot of other diseases, you want to catch it early and get it treated. And if you catch it the first year that your blood pressure is elevated and you keep the blood pressure down, it'll never cause any of the damage they're going to talk about. Because unlike, let's say, diabetes, where we're concerned about the blood sugar, but even if we get the blood sugar down, there are other things going on in diabetes that can cause you harm apart from how high the blood sugar is. Whereas with hypertension, if you keep the blood pressure down, and from the time it was discovered, it's always acceptable, you won't have any of the damage to your organs that high blood pressure wants to do. So that's the encouraging thing. And even though by the way, I think you'll agree with me, most of you remember this campaign that started in, I think, the 80s, maybe the 70s. You remember the marketing campaign for increased awareness of hypertension was the silent killer. And even though that sounds a little dramatic, the truth is that's true. I mean, most people, I know there are people who say, I can always feel it when my blood pressure's up. Usually it's the other way. Something has you tense and your blood pressure goes up rather than the high blood pressure causing you to feel tense. But for most people, they don't feel their high blood pressure. So if you know you've got it, and it's not just a one-day thing, you've checked it a number of days and it's elevated, it needs to be treated. So I think most of you know that. You're the savvy ones. We get the ones who already know a lot who come to this, and that's good. That's great. So welcome. With that, I want to introduce our presenters. We have two young resident physicians. Ladies first, Dr. Safina Ali is a second-year resident with us who went to medical school in Pakistan. Welcome. She's an outstanding young resident. And Rasim who is also from Pakistan. Pakistan is well represented today. And I know I've told Safina this, but I haven't told you this. A few years ago, I got in the end of a radio program on NPR, and I never really heard what all the guy being interviewed was about, but he had been very successful internationally as a business person, and at the end of this interview, the interviewer said, well, what secrets have you learned from your success internationally? He said, I don't know what secret. Well, I have learned this, that the hardest working people in the world are Pakistani. So you got to live up to that.
I'll try my best.
Kind of. So Rasim Shah is they're both from Pakistan. Listen, there are a lot of medical schools in Pakistan. I mean, dozens and dozens and dozens of medical schools. Which one did you go to?
I went to Liaquat College of Medicine and Dentistry. It's in Karachi, which is like a major city in Pakistan.
And Dr. Shah, you went to
I
Ross
actually,
University.
I went to Ross University, which is, the first 2 years is actually on Barbados, where I met my wife, actually. And then I did my clinical training out in Los Angeles. I'm not from Pakistan. My dad is from Pakistan, and my mom's from Guatemala, so I'm half Hispanic, half Pakistani. But I was actually raised in Pine Bluff, Arkansas. Anyone from Pine Bluff here? So, yeah.
Yeah, I was asking him what he knew about Arkansas. He doesn't know about the Buffalo River. He doesn't know about a lot of things up here. He said, we don't have that in Pine Bluff.
Yeah, we got Lake Saracen and that new casino out there, so I don't know if you guys want to go visit that. That's pretty much it, and the paper mill. So,
Dr. Momina Makeen, she has a very interesting background in medical school. I was not aware, I admit humbly, that there was a women's medical school, and apparently there are several, but that's in Dubai, right? And she went to, tell me the name of the medical school.
It's Dubai Medical College for Women, and it's like when I was a student there, like the only man on campus was the dean, and all the rest of the professors were like women, and we used to have like, it was all women all the time, so it was an interesting environment.
Well, there's been a transformation in this country of women in medicine. There were only 10 out of 150, a class of 150 that when I graduated, 10 women. Can you believe that? That was it. Yeah, yeah. Well, can you believe now that most medical schools in the U.S., most medical schools in the U.S. now are at least 50% women, and there are quite a few that are majority women. I think personally it's been a really good thing for medicine. I think the feminine touch in medicine was, anybody who thinks it wasn't being missed needs to look around and realize how things are now. It's a very good thing. So who's going first?
I'll be going first.
Okay, I'm gonna give it away to the experts.
Okay, thank you for the wonderful introduction, Dr. Wright. Again, I am Dr. Shaw. You will see me around this beautiful campus, and I can't wait to meet all of you guys and also learn from you guys as well. And also, hopefully I can help you guys as well throughout our time here. So today I'm going to be discussing hypertension. The prevalence of hypertension, especially at the age group around 65, is pretty high. So I would assume that most of you guys are very familiar with the term of hypertension. Anyone in here not familiar with that? See, okay, great. So we'll go in and kind of talk about what is hypertension. Hypertension, also known as high blood pressure. That's when the forces of the blood against your arteries are really high. So do you guys know what arteries are? Yep, okay. So that's the delivery system of blood in your body. So when that pressure is high, you'll have a high blood pressure. So what is a normal, quote unquote, blood pressure for folks? Generally, it'll be 120 120/80. Do you guys know what the top number is and the bottom number is? Anyone in here not know what the top number and the bottom number? Okay, I can explain that. So the top number is also known as the systolic blood pressure. That is the blood pressure after your heart actually pumps blood into those vessels. Now, the bottom number is this diastolic blood pressure. So that is the pressure once the heart is in its filling phase, or when blood is returning back to the heart. So that's what those numbers signify. Okay? So what is considered high blood pressure? Now, there's a lot of different stages in terminology that go with a high blood pressure stage. There's pre-hypertension, there's stage 1, stage 2, there's hypertensive urgency, there's hypertensive emergency. So there's a lot of different characteristics for these blood pressures. So generally what we consider a high blood pressure is going to be 130/80. And again, we'll go through the different classifications and when we want to treat that blood pressure or whatnot. So why is this an important topic of discussion, right? So hypertension is one of the most common diseases out there, and it leads to so many different complications. So that's why we really want to treat it in the earlier stages before you have all these downstream effects. So again, hypertension is a very common disease in a lot of people, not just the elderly, and is a major risk factor for serious health problems. Big ones specifically is going to be your heart attack and stroke. So we would definitely want to catch it early before you get to those stages where we have one of these complications, right? Again, what Dr. Wright mentioned, I didn't know there was a campaign in the 70s that called it the silent killer, but a lot of doctors use the terminology as hypertension being a silent killer because you don't really know when you have high blood pressure, even though you may think you do. More often is that you notice when your blood pressure is really low. You start to become dizzy and starting to kind of passing out. But with hypertension, you really don't notice it until you have a really bad complication. So the prevalence or the commonness of this disease in elderly population, over 70% of adults aged 65 and older have hypertension. So yeah, that's a lot of folks. If you don't have it, then you definitely know someone that does have it. So it's a very common disease. So again, I kind of went through what these numbers are. Again, the blood pressure is the force of blood pushing against the walls of your arteries as your heart pumps. And we kind of discussed the systolic and diastolic blood pressure. So if you have are you guys familiar with this device here? Yeah. Yeah, so this is an at-home blood pressure monitor. So again, the top number signifies the systolic blood pressure or the pressure after your heart beats, and this is the pressure of the vessels once your heart is kind of filling up. This number right here is just your pulse. It just monitors how many beats per minute your heart is doing. Typically, once we have a patient that has hypertension, and we're treating it, right? We'd want you to have this machine and actually make a log of your blood pressure. So if we have a physician to ask you, hey, do you have a history of what your normal blood pressures are at home? We'd want you to kind of take your blood pressure maybe twice a day or maybe 3 times a day and just give us the average of the top number and the bottom number to kind of give us an idea of what your blood pressure is at home. So what causes high blood pressure? So there could be a lot of different reasons for it. Commonly, it would be narrowed arteries, and they become narrow or stiff because of aging, and also like another common one is like lipid buildup in the or plaque buildup in these arteries, which can cause these vessels to become very stiff and lead to a really high blood pressure. So that's one cause. Another cause is extra fluid in the body. So with some patients who have like kidney disorders, you're not filtering fluid as properly as you would, you can lead to backup of fluid into these vessels, and this can also cause a high blood pressure as well. And then normally, when someone is exercising, that can cause a high blood pressure during exercise. But this is usually, normal or physiological. This is what we want when we are exercising. Again, some common causes are aging. Naturally become stiffer with age, your vessels. Lifestyle issues such as, poor diet, lack of exercise, obesity, smoking, and excessive alcohol use. And also genetics plays a role in this too. If you have a family member, like a parent or a brother or sister, really close family members that have hypertension, you're also at risk of getting it too. So this is the, again, is known as the silent killer disease because it's usually unnoticeable. And some of the things that can, present with hypertension is sometimes you can get headaches, severe headaches, usually at the back of your head, also known as a tension headache. You can feel lightheadedness or unsteadiness in some cases. There's some evidence of high blood pressures leading to like nosebleeds, blurry vision, and chest tightness as well. Usually when we see these symptoms is when a patient is having really extreme high blood pressures. Usually a systolics systolic is going to be like upper 180s. And then that's when we can start to notice some of these symptoms start to come. And some of the major complications with chronic hypertension, you can have heart disease, heart attack. The reason why you have these heart attacks is because of the narrowed vessels, right? So with chronic hypertension, your vessels become more narrow, and once that happens is you're not perfusing or you're not delivering blood to certain parts of the heart, which can lead to what we call myocardial infarction or a heart attack, which is, again, just decreased blood flow to certain parts of the heart, which can lead into heart failure. So if you are, have a heart attack, right, or have decreased perfusion or blood flow to certain parts of the heart, that can actually lead to weakening of that muscle, which ultimately leads to something called heart failure, where your heart is not pumping enough blood to your organs, and actually you start to become fluid overloaded. Does everyone know, has everyone heard of that term fluid overloaded at all? So again, certain types of heart failure can lead to like blood, instead of going forward into the different organs, it actually doesn't go out of the heart and actually leaks back into the lungs, and it could cause trouble breathing, shortness of breath, in that kind of scenario. So that's what we kind of call the term fluid overloaded in those kind of patients with heart failure. So again, prevention is key here. If you have hypertension, we definitely want to control that so you don't go into a heart attack or a heart failure. Another one is a stroke. And are you guys familiar with the term stroke? Yeah. So again, what is that? It's kind of the same kind of thing with a heart attack, right? You're just not getting blood flow to the brain because of narrowed narrowed vasculature. So this can lead to something called an ischemic stroke, which means you're not getting oxygen to parts of your brain. Or sometimes with really high blood pressures, you can cause something called a hemorrhagic stroke, where there's some vasculatures that you're getting too much of a pressure, which causes these vasculatures to actually burst in the brain, which can lead to a hemorrhagic stroke. So that's another complication of really high blood pressures. You can get an ischemic stroke or a hemorrhagic stroke. Another one is kidney damage. That's a really big one too, and that leads to a lot of different complications, and we don't want that. Again, this is very kind of similar situation. Not getting good perfusion to the kidneys. The cells in your kidneys start to die off, and you start to go into kidney failure. So that's another really bad complication of chronic hypertension that we definitely want to avoid, for sure. Vision loss is another one. Aneurysms. Have anyone heard of aneurysms before? Yeah, so that just, let's say you have like really high pressures in one of your vasculature and it's not going forward. What happens is the vessels behind the blockage actually start to bow out or start to get larger because there's no forward fluid motion, and that can actually rupture in some cases. Again, that can be in the brain or different parts of the body as well. And then there's peripheral vascular disease. You know, there's going to be some patients who have really bad peripheral vascular disease. Again, it's a blood flow issue. Mostly patients complain of like leg pain with that one, especially on exertion or when walking. And sometimes this will require, you know, revascularization, either with a stent placement or through surgery. So again, a lot of these things can be avoided if we just, you know, watch our blood pressure. Okay, so here's kind of a graphic of what I mean by the blockages here. So here's a plaque right here, and as you can see, it's easier for fluid to come down a clean artery versus one that has this blockage here. So again, this is kind of explaining what I was talking about. And how do you spot a stroke? There's this mnemonic here, be fast. So if you see someone who's having balance issues or someone complaining of this really bad new blurry vision, or if you see someone having a facial droop, arm or leg weakness, speech difficulty, that's when you want to go ahead and call for help. Okay. And then here are some common signs of a heart attack as well. You'd have usually this chest pain, which sometimes can radiate to the left arm. You could have some lightheadedness, some jaw pain or neck pain. Shoulder discomfort is a very common symptom as well, and shortness of breath. All right, and now I'm going to pass the mic over to Dr. Ali, and she will finish off the presentation.
Hello, everyone. First of all, thank you so much for joining us for this discussion today. It really means a lot to us. All right, so I'm going to go over my slides now. So now that we have talked about hypertension, let's also talk about how it is diagnosed. So what is needed for the diagnosis? We usually recommend 2 or more readings taken on different days at a healthcare provider office to make that diagnosis. And as we all know, the normal blood pressure is less than 120/80. So usually to diagnose blood pressure, the blood pressure has to be consistently more than 130/90 at more than one occasion on different days. Let's see. So the American Heart Association has a really good picture which classifies blood pressure in different categories. So as you see, normal, Systolic, or the upper number, is less than 120. The lower number, less than 80, is normal. So elevated blood pressure is, the upper number is 120 to 129, and the lower number is still less than 80. And then to diagnose high blood pressure, there are two different stages of high blood pressure. So there's stage 1 and stage 2. Stage 1 is 130 to 139 upper number and 80 to 89 lower number. And to diagnose stage 2 of hypertension, the upper number has to be 140 or higher, and the lower number is 90 or higher. And then there is hypertensive crisis, which is the upper number is higher than 180, and the lower number is higher than 120, and that is when you really need to consult your doctor immediately so we can do something about it. All right, so now let's just talk about, once the diagnosis of hypertension is made, let's talk about how to manage and treat that. So first line is usually lifestyle changes. That's what we want. There's this really cool diet. It's called DASH diet. It stands for Dietary Approaches to Stop Hypertension. And it is recommended by American Heart Association as well. It focuses on fruits and vegetables, whole grains, lean proteins like fish, poultry, beans, and low-fat dairy, and nuts, seeds, and legumes. It also focuses on limiting sodium intake, so ideally sodium intake of less than 1,500 milligrams daily. Also focuses on limiting added sugars and like saturated fats. And this diet is really, really good to manage hypertension just by like making those lifestyle changes. Physical activity, as we all know, it's not just important for managing hypertension, but also for our overall health. So it's recommended that we engage in 150 minutes of moderate intensity exercise per week. So that would include like brisk walking, and then 75 minutes of vigorous activity like jogging. So either you could do the 150 minutes of just brisk walking per week, or like 75 minutes of vigorous exercise like jogging. All right. And this is just a picture that shows different components of DASH diet. So you see grains, cereals, fruits, vegetables, meat, fish, chicken, and then dairy, nuts, and seeds. And it has all the portions also. So that's really helpful. Okay, weight management. Weight management is one of the most important changes that you can make. It really impacts hypertension. So even like a smallest change in your weight, like if you lose even a modest amount of weight, that's gonna significantly impact your blood pressure. So that is really good. Alcohol consumption is also linked to high blood pressure. So limiting alcohol, for men, it's recommended to limit it 2 drinks per day, and for women, it's 1 drink per day. All right, tobacco. So smoking really damages our arteries. That can cause high blood pressure. So quitting smoking helps with the blood pressure as well. And then chronic stress can lead to high blood pressure over time. So stress management like yoga, meditation helps with high blood pressure as well. All right, so once we make those lifestyle changes and we still have like high blood pressure, then we think about medication. So when do we use those medications? So for stage 1 hypertension, after making those lifestyle changes, still elevated, and there are other risk factors like heart disease or diabetes, then we would start medications. And for stage 2 hypertension, it's really generally recommended to start medications. And then some of the common medications that we use, so there are different categories over here. Diuretics, which we also call water pills, like furosemide, aldactone, that you guys usually use. They help eliminate excess sodium and water. So they help excrete the fluid, and that helps with the high blood pressure and lower blood pressure. Then we have ACE inhibitors. So ACE inhibitors are medications like lisinopril. They relax blood vessels by inhibiting a hormone that narrows our blood vessels. So they relax our blood vessels and lower blood pressure in that way. And then angiotensin receptor blockers like losartan, they work in the same way as ACE inhibitors. And then we have calcium channel blockers like amlodipine. They also work in the same way, relaxes our vessels and help with the blood pressure. And then we have beta blockers like metoprolol. They basically decrease our heart workload and reduce blood pressure in that way. Let's see, and then just common strategies to manage our hypertension. Make sure to schedule regular checkups with your healthcare provider, and make sure, as Dr. Shah mentioned, to keep a log of your blood pressure at home and bring it to your doctor's appointment so we can see the trend and make any adjustments if needed. All right, and I think that's all. Thank you.
Great. I think that's a great overview of hypertension, and some of the words he asked you if you recognize, like stroke. I think that's pretty much everybody are familiar with some of these terms that are such important conditions, and they often relate to hypertension. So thanks. I think that was kind of the summation that I was looking for. And would be glad to, hypertension's tricky to manage, to diagnose, to treat. It's tricky, even though it seems to be straightforward. If we get alarmed about your hypertension, what happens to your blood pressure? It goes up, it doesn't go down. And it's really important to get the diagnosis right at the first, not to, they mentioned a couple of times, not starting a medication on the day one, the first day you're found to have an elevated blood pressure in the clinic. First of all, many of you are aware that my guesstimate, not based on any firsthand research, but my guesstimate is probably half the people that live at Butterfield Trail would have a higher blood pressure when they're in the clinic than they'll almost ever have at home. And since our goal is to get a fix on where your blood pressure is most of the time, not just in the exceptional times, especially not just the exceptional times. What is it most of the time? It's going to be more reliable to look at the log you take at home of where your blood pressure is. And then the precise way, I wish we need to preach this more often, but the precise way of checking it is to sit down for 5 minutes before you check your blood pressure. Be sure you're at rest sitting. 5 minutes, and then take it twice and take the average of that. And I think most people, not everybody, most people will if they do take it when they first sit down and then take it again in 5 minutes, they'll see a difference. It's fallen a little bit. That's often the case anyway. But especially when we're trying to determine, is there a diagnosis of hypertension? You don't want to overreact to the other thing is, everyone fluctuates some. If you had your blood pressure around the clock, had it monitored around the clock, you see there's a fair amount of fluctuation, and you don't want to catch the person over 160 and make your diagnosis based on that, because that same person may be 120, an hour later. So getting a fix of where you are most of the time is really, really important. Are there questions? I thought there would be.
I can talk loud. Given that all of us at Butterfield are active, eating healthy diets, watching our weight and keeping track of our blood pressure, we're in a good shape. But the rest of the population, and especially the generations coming up who are living on fast food, sitting and playing on the computer, their phone, and look around you, the gross obesity in younger generations. But do kids get their blood pressure taken? I don't remember that.
I'm never in a pediatrician's office either, but I'm told that, yes, it is. Uh, those are really good points. I think that fast food really bothers me because that doesn't come with less salt. It comes with more salt. And salt is a big thing here. Smoking is a big thing here. Alcohol is a big thing here. You know, the good thing about those things is they're modifiable risk factors. I mean, we can do something about those. There's some things like your genetics that you can't change, but really good questions.
How do you feel about these wrist monitors rather than that using the,
About like a smartwatch monitor, or
Well, it's just instead of an arm cuff, it's a wrist cuff.
oh, it's a wrist cuff that monitors blood pressure. I didn't even know that was a thing.
Oh, yeah.
I don't know. Are those?
That's,
I feel like if you're
they're better. When they first came out, they're really, I think most doctors tried to avoid it. But I think they're, I was in the dentist today and got mine checked on my wrist. I guess it was normal. I wasn't checking it against another one, but I think the criticism I heard about it when they first came out, I don't hear much anymore. So I think they, like so many products, they've become more reliable. Easier, yeah. I'm still, they actually make finger detectors. I wouldn't trust that one. I'm guessing. Yes.
You mentioned the ACE inhibitors and the hormone that causes an increase in the vessel or something. I didn't understand that.
So the ACE inhibitors is your question. How does that work? So
And what hormone causes
Okay.
that increase?
All
is
right.
the question.
sure. So, oh, do you want to answer
I'm
that?
just going to say it's not male and female hormones that they're talking about. Other.
So it basically works on a hormone, it's called angiotensin 2, which is a hormone that basically narrows our arteries. So how that medication works is it inhibits or stops that hormone from working. So that causes relaxation of those arteries, and that causes to lower blood pressure. So that's how it works.
So where that hormone come from?
It's normally circulates in the body. It's a normal, actually from the kidney. Use the mic.
So a lot of it, the kidneys are a big factor in blood pressure control, basically. So there will be times when, kidneys will be like, well, we're not getting enough blood coming to us, so we have to do something. So there's release of like certain types of hormones which increases because of that. But that's very maladaptive. It's not really good for us in the end. It's just their way of reacting to whatever's going on in the body as per when it comes to blood pressure. So we have to make adjustments there so people don't get hurt by our own bad reactions to disease, basically. That's how it works.
Yeah, I have a question over here.
What do the ARD blood pressure, what do the ARD medications like losartan, I think it's one of them, what do they do in the body?
So again, that one is like another hormone-related one. So that's an aldosterone receptor blocker. So that's another hormone that, what aldosterone actually does is, it's released from the kidneys. So there's glands on top of the kidneys known as the adrenal glands. So those glands, they release a hormone known as aldosterone. And what aldosterone does is it tells the kidneys to reabsorb sodium. So when sodium goes into the vessels, water follows sodium. And that leads to swelling of the vessels. Oh, angiotensin receptor, sorry about that, yeah. It's angiotensin receptor blocker. Sorry, aldosterone is a different one. Sorry about that.
And it works in the same way, but it has less side effect profiles. So for some people who cannot tolerate ACE inhibitors, they will have side effects like cough, chronic cough, or sometimes people would have a really bad reaction like edema of their face. Then we use ARBs or like angiotensin receptor blockers on those patients, and it has a good, it has a less side effect profile. It does not cause chronic cough or like swelling and those kind of side effects. I mean, in theory, any medication can has reactions, so it really depends on different factors. But if you get a rash from any medication, I think it's a good idea to stop it and switch to some different class.
Something, I might just, okay, right here. Let me just make a comment while it's on my mind. It's not on my mind now. You pass it down this way.
Address the smartwatches.
Oh, so sorry.
Address the smartwatches for blood pressure or
I haven't seen any smart watches that actually measure blood pressure. Usually they just measure pulse. There's some that say they have a EKG function on it, but the reliability on those is not very great. But no, I haven't seen a smartwatch that measures blood pressure.
There is an app, or more than one out now for smartphones that does check your blood pressure. I don't have any direct feedback as to how reliable, but you can imagine if they're getting it on the market, it's pretty close to as reliable as we want it, and it'll only get better.
Two questions. I've been told by a couple of cardiologists that older people just have higher blood pressure. They don't worry about this, the normal blood pressure that you're talking about, and the high blood pressure that you show, they don't seem to be concerned about that at all. So that's one. Two, I don't think I have ever been in a doctor's office where they checked blood pressure in both arms. But a friend of mine recently had some differences in the left and the right arm, so she asked that it be investigated, and she wound up having a stent.
There is a somewhat rare condition that can cause that asymmetry. Well, there's a somewhat rare condition that can cause that, and a blockage up in the central arteries. It's pretty rare, and if there's some indication that, one pulse is weaker than the other, that's what usually causes people to even check it on both sides. But it's a good thing to find if it's there. Okay. What was the question?
In terms of the blood pressure, like being a little bit higher than what we reported. Yeah, so I think it was the JNC8 guidelines for adults with age greater than 65. Usually if they have a blood pressure less than systolic 150 over 80, that's when, that's our target goal, is for it to be less than that. And if it's over that, then we'll generally treat it. So if it is a little bit higher in terms of like in the 140s, less than 150, then usually we won't be as aggressive in terms of giving you management because of the risks of, someone, having too low of a blood pressure and someone being a fall risk and whatnot. So, yeah.
One of the things that happens with age to all of us is he referred to stiffness of the arteries. And you remember the old term, hardening of the arteries? That's the person who has stiffer arteries over time from blood pressure, but also because of plaques narrowing it and causing that. One of the problems made more difficult in an older adult population of patients is being sure you're not going to run the risk with treatment of high blood pressure to have a person running too low. Under 120, for every 5 points under 120, it becomes as risky as 5 points above 140. So, and there's also the pretty strong feeling around a lot of the experts, and I've seen this in a lot of the cardiologists here, that it requires, because of the stiffness of the blood vessels, it requires a little bit more blood pressure to perfuse the circulation completely. So that all those things kind of influence what we find acceptable on. The only thing that makes me nervous about the lower stages is, yes, technically you could say hypertension, but I wouldn't want to put somebody on a blood pressure for, on blood pressure medicine for blood pressure that never was, that stayed around 130, because you're going to more run the risk of bad things that happen when it gets too low. Especially with that fluctuation we're talking about, everybody does some fluctuation. Yeah, you can get it under 140, you can also get it under 120 and start having problems with that. So, Dr. Helen, you had a question?
Well, I have more of a story than I have a question. But my story refers to something that happens to me, and it's white coat syndrome. I think you referred to that just a little bit, and that has to do with the fact that when people go to a doctor's office, their blood pressure is high because they are anxious about what's going to happen to them in the doctor's office. I happen to be one of those people. I have one of the worst cases of white coat hypertension that can ever be. And so I went to the clinic recently. I had to go, needed to go, and they insisted, of course, on taking my blood pressure, which they did. It was 190 over something, which of course is in the range of a heart attack or a stroke. Well, I was pretty upset about that. So when I got to talking to the intern and Dr. Swindell, I wanted to talk about this. And I said, they knew, of course, what it was. And I said, what in the world can I do about it? Dr. Swindell said, stay out of doctor's offices. But I want to ask a question now, and that is, there's such a thing, I think, as isolated systolic hypertension. What's that different from any kind of hypertension?
So the question was, what's the difference between an isolated case of elevated systolic blood pressure versus chronic elevated systolic blood pressure? I think you actually gave us the answer. If you're anxious, that can lead to a higher blood pressure that's not normally high during your normal activities of life. So in that sense, we usually don't treat someone with a white coat syndrome.
Well, I think when people have persistent, the term isolated systolic hypertension really, for the most part, is separate from white coat hypertension, but it is someone who systolic blood pressure will be up pretty consistently, even though the diastolic is fine. And that's not the rule, but that's the exception. What the studies have pretty much all shown is that in older adults, the systolic has more to do with outcomes, strokes and other things, than the diastolic does. It's not that we're not worried at all about the diastolic, but it's the systolic that seems to be present in most studies where there are complications. True white coat hypertension Helen, is what you had the other day, and then go straight home and it's normal. And I've seen a few of these people in my career, and I mean, 220 over 120 is not uncommon, and they call back after they get home and it's 135 over 80. Now, that's really, and that's different than what I was talking about when I said about 50% at Butterfield are going to have higher blood pressures in the clinic. They may be 158 in the clinic and 145 when they get home. And that's why I don't rely on the clinic readings for the main decisions. I really want to say where you are most of the time. But that's what I was saying at first. It makes treating hypertension kind of tricky.
One of the things that happens to my readings of blood pressure, and I think other people as well, and that is there's a consistent difference in the readings depending on whether, say, it's in the morning or in the evening. And so my question is this: I have heard that sometimes it helps to take your blood pressure medication at a different time. And I wonder how you feel about that. In other words, if it is higher in the evening, should you take your medicine later on in the day?
Sometimes I think that's true. Sometimes, Dr. Helen, for sure. And I do think it's a good idea to know where it is at other times of the day, even if you're still going to primarily follow your regular checks in the morning. It'd be nice to know what it is in the evening occasionally too, so that you know you're not missing it being much higher or much lower. Did you have a question?
Yeah, I do. What if you're already on blood pressure medicine? Should you be doing a log, even if your doctor hasn't told you to do a log before you came in? Because you're kind of saying that, and I think that's a grand idea.
I think if you ask your doctor, say, yeah, that is a good idea. I mean, we forget to say that, but it's not a bad idea. Now, if you've been really stable for a long time, your blood pressure medicine hadn't been changed because it's been so rock solid normal, then how often might be once a month. But whatever periodic basis I suggest to a patient to check it, based on their being so stable, I basically say, now if you get one that's high, then maybe check it every day for a few days. Be sure that's not where it's living now, And if it is higher than what we're used to, maybe we need to sit down and talk about it and review it. No, I think it's a good, no matter how well controlled you are, to check it periodically, just to know. It's a good point. Other questions? These are great questions.
For many years, I've had very low blood pressure. And some years ago, a doctor told me to eat more salt. Do you think that's wise advice?
Well, can I say that I don't want you to expose your medical history in the crowd, but if you're not on high blood pressure medicine, then frankly, what is a good blood pressure? The lower the better, as long as you're not dizzy. And I get nervous with someone's 100 over 60. But if they're doing that without medication, I pat them on the back. That's a good thing. Lower the better if you're not dizzy. You're the exception. You're the. Any other questions? These are great. Thank you so much. Hope this was helpful. And if you have some ideas about what you'd like to hear about, let us know. If it's appropriate for the whole group, we'll try to put something together that way. And again, I want to thank you so much for the encouragement you give these young doctors. It really is. It's how gracious people at Butterfield are. I understand that, but it's genuine and it's always well received. And everybody likes a pat on the back every now and then. Sometimes we don't deserve a pat on the back, maybe, but thank you.